The demographics are very similar. The broad policies, if you like, the container that these teams actually work in is exactly the same. And yet in one of these wards they've actually got a length of stay of 14 days and a readmission rate of 8% within 90 days. The other ward, they've got a length of stay of 60 days and their readmission rate is 16%. Now I've spoken to staff over there and I've tried to find out what on earth makes the difference. And one of the things seems to be the cup of tea with the doctor's part of the team, we don't have ward rounds, we have short meetings sort of factor. It seems to me that they're able to turn on a sixpence. Now that's the tip of the iceberg. I think below that tip is a level of professional trust and respect and a high level of engagement, a real sense of only those people that need to come into hospital come into hospital. And when they do come into hospital, there's an understanding that they jolly well need to be here, and there's an understanding of actually what they need from the team. The team with a long length of stay, my view is that they spend a couple of weeks, the nursing staff in particular, spend a couple of weeks trying to work out why the patient's actually been admitted to hospital. So the patient might come in with a few words in the medical notes, very little more. They might come in for assessment. They might even come in with the dreaded social admission, or they've come in for respite or whatever. They've come in largely because other people have failed to cope, often. And there might not be a very good psychiatric, indeed, let's explore that very slightly further. There isn't actually a psychiatric emergency which requires admission. It's a combination of other things, ranging from the family have had enough to the housing's broken down to the CPNs are burning out. But very rarely do those patients need to be there. What tends to happen then, in this particular service, is that the nurses actually think, well, we're going to do something. The managers will be honest. If we don't have 2 or 3 care plans written, if we don't have those things updated. So they nurse by telepathy. The nursing assistants are running around looking after the patients while the qualified staff broadly are sat in the office writing care plans, which probably very few people will read, which are largely meaningless and which are never an expression of a multi-professional intent to treat. As a consequence, patients come in, and I would say that their admissions are not purposeful. And if you push me, if I had to define what a purposeful admission is, I'd probably say that the patient knows why they're coming in, and so do the TACs, to the team that are looking after them, I should say. So everybody knows why the patients come in. You've probably got discharge criteria set. So if somebody's, I don't know, if somebody's doing a lot of drugs and they're suicidal and there's a possibility of an underlying mental illness, your discharge criteria would be to assess the extent to which the